As a member of the panel, you'll consider 7 research topics which were selected by an advisory board of patients, clinicians, and researchers. The information provided in this module for the pSCANNER Stakeholder Research Prioritization Panel serves as a general introduction to the state of the science on Kawasaki disease. You may review this entire presentation at once, or you can jump right to the section that covers each research topic. Kawasaki disease is a rare childhood disease that involves vasculitis, which is swelling of all types of blood vessel walls in the early part of the disease, known as the acute phase. KD also affects lymph nodes, skin, and the mucous membranes inside the mouth, nose, and throat. If caught early and treated, most children can recover. If untreated, however, one of the most concerning complications is coronary artery aneurysm. An aneurysm of the coronary artery is an abnormal expansion of the largest heart vessel. This happens in up to 1 in 4 children who don't receive treatment. This has become the most common cause of acquired pediatric heart disease in developed countries. The inset shows an angiogram of a young adult who presented with an acute heart attack. The white arrow points to a blood clot in the large aneurysm in the left coronary artery, which was the cause of the heart attack. As a child, this young man had been misdiagnosed with scarlet fever, and his Kawasaki disease was not recognized until his acute heart attack. One important challenge in KD is figuring out who has it quickly. The treatments we currently have available are most effective when administered early in the course of the disease. Administration of treatment within the first 10 days of fever is associated with the best outcomes. Once aneurysms have formed, the damage is permanent, even in patients who fill in the aneurysms with scar tissue. Patients with large aneurysms are more likely to have significant cardiac complications as adults. Sadly, we don't know what causes Kawasaki disease. Research has previously focused on looking for possible infectious agents in body fluids and tissues, such as fungus, bacteria, or viruses. So far, we've not found an infectious agent that causes Kawasaki disease. In newer research, scientists are looking for possible causes that include a new virus that we've not previously known, or a toxin or other substance carried on airborne particles. Currently, there is no known way to prevent KD. Many researchers agree that something in the environment triggers KD, but only in genetically susceptible children. Seasonality is an important feature of the illness. In the U.S., the seasonal triggers for KD are most common in the winter and spring months. Kawasaki disease was initially recognized in Japan in the 1960s, and the number of cases has been steadily rising. This chart shows 3 peaks in the number of new patients in 1979, 1982, and 1986. These were nationwide epidemics. Some people think this pattern suggests the introduction of a new agent or environmental trigger into a highly susceptible population. Japan is the country of highest known incidence in the world. In Japan, there are 260 new cases per 100,000 children less than 5 years of age. In 2013, there were more than 14,000 new cases diagnosed and treated. Based on these numbers, 1 in every 85 children in Japan may develop KD during the first 10 years of life. We don't have an accurate number of cases of KD in the United States. Using data from U.S. hospitals, the Centers for Disease Control and Prevention has estimated that there are around 5,000 to 6,000 new cases diagnosed each year. This may be an underestimation of the true burden of disease. We're also trying to develop more accurate information at the local level. This graph shows the number of Kawasaki disease cases at Rady Children's Hospital in San Diego in the last 10 years. There's been a gradual increase in numbers of cases over the last decade. Using local data in San Diego County, we've estimated how many children might develop KD. In the population of 3.2 million people, the incidence is 48 cases per 100,000 children younger than 5 years of age. This means that 1 in every 2,000 children may develop KD. These estimates are based on active surveillance of cases and thus are more accurate than the national statistics cited by the CDC. Genetics plays an important role in determining susceptibility to KD. Data on race and ethnicity of those with KD points to genetics as a possible explanation. Children of Asian and African American descent are overrepresented among those with KD, which points to a possible genetic link. Similarly, there's a higher rate of KD among siblings, as well as a higher rate among parents of KD patients. At this point, you may continue to listen to the presentation on all 7 possible research topics, or when you're in Expert Lens, you can click the link next to each topic and jump right to the section that covers that research topic. For each area, we provide key definitions and a brief overview of important points from current research to think about as you consider the topic. Topic 1. Compare the effectiveness of diagnostic tests for early detection of KD. Emergency departments and urgent care centers need a Kawasaki disease diagnostic test. For example, 3 million people live in San Diego County. 94,000 children a year visit Rady Children's Hospital Emergency Department and Urgent Care. 7% of these visits are for fever, which is one of the common early signs of KD, but only 80 to 90 children will have KD. The trick is finding those children quickly enough from among the many who show up with fever. Unfortunately, there is no test for Kawasaki disease. Based on signs and symptoms, KD is frequently confused with other infectious diseases of childhood. A healthcare provider uses observation of the child to make a diagnosis of KD according to classical criteria, which includes the presence of fever for 5 or more days, combined with at least 4 of 5 signs, without any other explanation. The signs are extremely red eyes without a thick discharge, a rash on the main part of the body and in the genital area, red, dry, cracked lips and an extremely red swollen tongue called strawberry tongue, swollen red skin on the palms of the hands and the soles of the feet, swollen lymph nodes in the neck and perhaps elsewhere. Various lab tests are also performed that may support the provider's observations in making the diagnosis. They include blood and urine tests that look for the presence of markers of inflammation. Tests look at arteries and heart function, and in some patients an echocardiogram is performed to find abnormalities in the coronary arteries. Other diagnostic tests or procedures might be done to make sure that the child does not have other diseases that present similar signs and symptoms to KD. Researchers are trying to create a diagnostic test specific to Kawasaki disease. Topic 2. Understand the types of education and ways that education can be delivered that will be most helpful to patients, parents, and caregivers so that risk of cardiovascular damage for individuals with KD can be reduced. The educational setting the majority of us are most familiar with is the schoolroom. We remember a teacher standing in front of the classroom, presenting a lecture and giving tests. But health education is different. Health education refers to offering general information about health and well-being to the overall public at large, or it refers to specific care instructions given to an individual along with his or her caregivers with a particular condition or illness. Cardiovascular refers to the heart and vessels. Coronary artery aneurysms are the most common and significant complication of Kawasaki disease. Early detection of KD and timely treatment within the first 10 days of fever are critical to preventing aneurysms. Longer-term cardiovascular damage may also be prevented through health maintenance activities. There is currently no research being done on health education that might be helpful to patients and parents in preventing cardiovascular damage from KD. However, in health education, there's extensive research about what is most effective for individuals with other chronic conditions, such as cardiovascular disease and diabetes. For example, health education may be conducted at different times. Initial education is often provided at the time of diagnosis, but may also be reinforced periodically at follow-up visits or in between. Research has also highlighted the importance of providing education in language and visual formats that are easily understood by those without clinical training. Since health education is meant to help patients and their caregivers improve their health, there are also tools for assessing whether they've gained the necessary knowledge and are able to use it in their daily lives. The lessons learned from research and other conditions have shown that use of different formats for health education might be effective. Health education can be offered in printed materials such as brochures and published on websites. But there are many interactive formats that are now in use. These include downloadable videos or interactive questionnaires. There are even educational smartphone applications that can target scheduled specific appointments or track symptoms and signs of an illness. Topic 3. Compare the effectiveness of tools for raising awareness among parents, caregivers, school staff, and other non-clinicians in order to increase early diagnosis of KD. Many pediatric illnesses share clinical signs with KD. Only one of these patients has KD. Making the diagnosis can be challenging, even for experienced pediatricians. Can you tell which child with a fever and rash has KD? This makes it very important that those who are frequently in contact with children are well aware of the potential signs of KD. Those in frequent contact include parents, caregivers, child care workers, school staff, and others. There are resources for parents that help to raise awareness of KD. Websites such as the Kawasaki Disease Foundation and the University of California, San Diego. Currently, there are no studies looking into the effectiveness of tools for raising awareness of KD. We don't know who has access to these tools, whether they effectively increase awareness, or how they can be improved. Topic 4. Understand whether and how algorithms can be applied to electronic health record data, for example, patterns of symptoms or test results, to identify possible cases of KD. An algorithm is a set of programmed steps designed to be followed in order to solve a problem or to complete a computer process. An algorithm can be used to automatically comb through large amounts of data, look for patterns, or analyze those data to find an answer. Electronic health record is a computer system that electronically stores a person's health and medical records and makes them available for use in the delivery of healthcare services. There are few research studies testing algorithms to identify cases of KD. The pSCANNER team is conducting a preliminary study to develop a tool to scan the electronic medical record to see if signs and symptoms of KD are present in physicians' notes. Using existing electronic health records may improve how we find potential cases of KD in the future. Topic 5. Compare different lifestyle change programs that address nutrition, physical activity, and symptom monitoring, alone or in combinations, to determine which ones are most effective in maintaining cardiovascular health after diagnosis of KD. Lifestyle changes. Lifestyle refers to the activities that individuals engage in regularly that are perceived to be under their own control. Since an individual needs to manage their heart health on a long-term basis, many treatments and therapies also rely on the individual to make lifestyle changes, such as good nutrition, engaging in physical activity, and having healthful sleeping habits. Symptom monitoring. A patient with heart disease may be taking numerous medications to avoid fluid overload, treat hypertension, and help with their heart and blood vessels. Some patients can have minimal symptoms, whereas others have severe symptoms. It's important to be aware of the common types of symptoms, monitor them, and know what one can do to manage them before they worsen. No research in KD or pediatric cardiovascular disease. Although no studies have been done in KD, many have been conducted in cardiovascular disease with adults. Research in cardiovascular disease. It's important to distinguish the effects of lifestyle change and self-monitoring from other aspects of health intervention. Lifestyle changes and symptom self-monitoring are often necessary regardless of whatever therapy is being delivered. Most studies of lifestyle change and self-management of symptoms in patients with cardiovascular disease have included many different components to the interventions. For example, one current research study is looking at the effectiveness of an intervention that includes education while the patient is still in the hospital. This is followed after discharge from the hospital with remote monitoring of vital signs and symptoms and health coaching by a nurse via telephone. This may contribute to preventing additional hospital admissions. One challenge is unpacking the effects of the lifestyle change and self-management component from the follow-up calls or home visits. Trials of long-term self-care education with frequent reinforcement have produced significant decreases in hospitalizations, but not a reduction in mortality. Topic 6. Compare medications for infants and children with specific characteristics to determine which ones have the best long-term outcomes with the least risk. Current medications for treating KD. There are a number of medications used to prevent aneurysms, reduce inflammation, and protect from cardiovascular damage. They're listed below. Treatment with intravenous immunoglobulin, or IVIG, reduces the aneurysm rate from 25% to 5%. It's the first line of treatment for KD. IVIG does not work for everyone. About 10 to 20% of KD patients do not respond to a single dose of IVIG and require additional therapy. There is no clear evidence to guide physicians in the treatment of KD patients when IVIG fails to control the inflammation. Many options exist, and the choice of second treatment varies from center to center. IVIG is also very expensive and not available in resource-limited countries. Currently, there are 4 active clinical trials in the United States related to drugs used for treatment of KD. They're listed below. None of these studies are comparing the benefits and risks of medications for children. Topic 7. Understand the long-term health challenges, both heart-related and non-heart-related, of individuals with KD. Long-term heart-related health challenges. There are a few studies on long-term heart-related health. Long-term health challenges following KD depends on the severity of cardiovascular damage. The extent of damage to the coronary artery is particularly important. One study found few cardiovascular symptoms after 20 years among children who had no detected cardiovascular abnormalities in the acute phase of KD. One study tracked long-term health challenges of individuals with KD with an online questionnaire. Another study based at UC San Diego, in progress, is open to all adults who had KD in childhood and is following health outcomes every 2 years with an online questionnaire. Lack of studies of non-heart-related health. Parents of children with KD reported lowered general health perceptions, suggesting long-term concerns about their children's health exist regardless of overall health status, but there is a serious lack of attention to these issues. Few centers in the U.S. are following all KD patients longitudinally. There's little tracking of the long-term health challenges, both heart-related and non-heart-related, of individuals with KD. Thank you for joining us on this adventure to improve the efficiency and relevance of research that we hope will lead to better health for all patients.